Have you ever been more ready?
Do we know what
I don't
episode
have like
number
a
this
pizza
is?
stain on me or something. Oh wait, I wore red intentionally.
So you can.
What's to hide the pizza stain?
Perfect.
Yeah,
Perfect.
just in case.
Italian Food Wednesdays.
Yeah.
Well, my wife's Italian, so
Is it Italian food every day then?
that's how I became a diabetic. So,
Happy ever since.
yeah,
Perfect. Well, thanks for coming in. This
sure,
is
thank
Dr.
you.
Keller,
absolutely.
Director of Informatics at IMS. Did I say it?
Yeah, it's a very prestigious title. I'm not sure what it means, but
Sounds smart.
Yeah, it does sound smart.
Yeah.
So, go ahead.
So you were at IMS and then you left and now we've come back. How many years has it been since you've been with the group?
Basically, so I'm one of the founders of IMS initially. So it started as a concept of bridging together primary care and specialty to work together to try to work through any, medical challenges with the focus being provide better care to the patient. So that integration helped with the concept of its name, Integrative Medical Specialists, IMS. So it was founded roughly 2004, 2006. I'm not sure the exact date. I left about 8 years ago, worked with Abrazo as the medical director at Abrazo for their outpatient services, known as abbreviated as AMG. Then went and helped Village Medical. You may be seeing a lot of their clinics with Walgreens. So their big thing is they co-locate their offices with Walgreens to provide integrative care. So I was the first physician hired and their key medical director to help move that project forward. Now by the end of the year, they're probably going to be at actually 40 co-located Walgreens. That's huge in 2 years. So left them, went back to IMS. The main reason that I went back is really related to care opportunities. And if you pick a situation where you get an opportunity to control or upgrade or improve, whatever you want to call it, opportunities to have a patient have a better experience. Better experience means they're more happy with their care, more confident with their care, they're more compliant with their care. That then in turn translates to healthier patient. They're not going to the ER as often, not going to the hospital as often. So you're improving cost, you're making a patient happy. What's a dynamic or a dream situation that can occur? That's at IMS. And the reasons they have an integrated primary care with specialty. And what's really cool is they have very open administration. So they have a team of, let's call them operatives that are working in partnership with the physicians to troubleshoot whatever's going wrong.
So
right?
are you saying it's business meets medicine to solve
business
the problem?
meets medicine the way it should be. It's not business leading medicine, all right? And we have entities here in Phoenix that run that way. It's not docs thinking they know better, because we have entities that represent that. I think both go the wrong direction.
Okay.
And if you really want to focus on the patient, you need a clinical angle. What is it that we have to do to improve care, and how do we get there? So you need operational experience. And that's what drove me back. And actually, we had a shitstorm today. That's one of the reasons I was running behind. And I think that was what I was dealing with on the phone on the way over here was a good example of that, where I reached out to our chief operational officer directly. And literally I called her and said, hey, how many minutes do you have to talk with me?
That's always a good start.
And she's like, why? What is it that I need to know? Then we started talking about our dog. Our dog's been sick, but I just said, look, I'm really pissed off. So you tell me how much time you're going to give me. And we just literally spent the whole, from my office to here, talking out what the issue was and coming up with a solution together. So operations clinic, I said, look, this is what I see. This is what's driving me, batshit. How are we going to fix this problem? Because we got to fix this problem. And you know what? She spent the time, we worked it out, and we're going to implement the solution. And actually, that's cool. And, you know, no offense to the other entities I work with, that's not something I'm used to.
Right.
You know, I'm used to, we can't do this, we can't do that, or that's not on the agenda, or we'll talk about this in 6 weeks. When I was at Abrazo, not that I'm picking at them, there's a joke as it related to corporate that everything takes 6 months. So we'll see where we're at in 6 months.
Yeah.
Well, that's too late.
That says it's okay keeping it broken for
Yeah,
6
yeah,
months.
it's
And I would
basically, we're
venture
too
to guess,
busy. There's other things we need to deal with. So
and I would guess that the reason you got so fired up is it had something to do with patient care.
yeah,
It's usually what fires up a doctor.
well, me especially. So
Yeah.
yeah, I won't talk about what it was. It,
No,
it wasn't
that's fine.
anything that's bad, dangerous, or
Sure.
would hurt people, but it's more operational efficiencies. We got to get smarter. We got tech, right?
Yeah.
It's like all this tech here in this room. We got tech. We need to use it smart.
Mm-hmm.
We need to use it in a way that's efficient. We need to help offload stress to our physicians, our staff, and our patients. And we all have to participate in that in some way. That makes it work. I
Yeah.
mean, tech can make your life a lot easier if you know how to use it and you implement it appropriately.
Sure.
And the nuance related more to that, but had a big impact internally. So, you know, got worked out. That's nice.
So I think it's very easy to feel patient stress. What's stressful for a physician?
I say what isn't stressful starts with my wife.
How many
I
minutes do
wake
we
up in
have?
the morning. Yeah, it's like
In relation
my dog
to-
wakes me up at 5 a.m, and licks my face. If I don't pet her belly, she goes out and pees on my carpet. So
Stress start.
then I have to go out and make sure she pees, then feed her. And if I don't feed her what she wants, she won't eat the damn thing. So then I got to circle back and, you know, tell my wife that I love her and give her kisses, or she texts me.
She'll pee on the
like,
carpet.
Yeah, it's like she'll pee on the carpet. It's like I got 2 pee stains that I got to deal with, right? Because it's my dog and my wife. Somehow
Or
I'm the
just
one
add a
that's
third.
responsible.
Yeah.
Yeah. You know, that's a very good question. So I'm going to answer it this way. And it's kind of what Steph said, where there isn't anything that isn't stressing us out. Unfortunately, specifically in my field, primary care, we're the quarterback, right? So if a team fails, it doesn't matter that you hired the wrong front line and they all suck. It's the quarterback sucks, right? You threw an interception. Well, I'm always being rushed. Well, we don't care. You suck. We're trading you. Well, it's a similar dynamic where if anything goes wrong in the concepts of care delivery, say I send you to a cardiologist, and that cardiologist is a fucking asshole. You know what you're going to do? Why'd you send me to the cardiologist?
Yeah.
Right? I thought he was good. So there isn't nothing that we're not responsible for. Also, if this cardiologist does a catheterization appropriately, it's on my metric because I didn't vet out appropriately whether you should really even see him in the first place. You wind up getting an unnecessary cath. That spent money, and I'm to blame. So for primary care, what people don't know is that we're responsible for everything that happens in every patient's care, whether it be Medicaid, Medicare, or commercial. That's, I think, a very fair definition of value-based care. It's what processes improve a patient's life, and how can we do it where we decrease the overall cost that patient's going to spend. And that's all primary care driven, 100%.
So then you're becoming quarterback and coach.
Everything.
You're
There isn't-
coaching the whole next play.
Correct. So the concept, and again, why I kind of went back to IMS, is to do a team-based care. So what team-based care is, we're going to segregate all the responsibilities into chunks. So our front office is going to have certain responsibilities to help offload the stress. So they're going to collect data for us. And it's really a lot of this about data. So, you know, do you drink? Do you smoke? Do you cavort about? You know, who you're secretly sleeping with? We need all
the
stuff,
people,
right?
the
Yeah.
full
So
list.
we need to have a team discuss this with you from the moment you call, check in, get roomed, me show up, and then the next visit. You can't do it by yourself. You cannot do it by yourself. So it's segregating that team. So you could say, I've been out of touch with football, so it'd be either a coach and or the owner, where we have to hire individuals and piece out these responsibilities. Otherwise, physician burnout maintains itself at a very high rate. So about 6, depending on the poll, what state, who you talk to, the burnout rate could be 60 to 70%, where people are saying, God, you know, there's a moment where I wanted to be an accountant. Fuck, I should have took it, you know? And I've been in those situations where maybe I should have gone into research, but all the researchers, well, excuse me, at that time had like this wild hair,
Right.
and they didn't shower. So I felt that was something that I wanted to.
And the doctors just were on point.
They were cleaner, right? They smelled better. So, and they also made a little bit more money.
Yeah,
So
yeah.
brand time, they didn't freak out, and their hair got more wild. That was kind of the pivotal point why I didn't do research. So anyway, yeah, it's crazy times, and all that responsibility is getting funneled. My job is to provide value to not just the patient, but to staff and to the physician community. So informatics is getting the information to move from A to B and develop processes that offload stress.
Yep.
Offload stress, improve care, offload stress. And actually, I like it. It's fun for me.
We had a lunch the other day, and I came back and I was dying to tell Nick all the things that you shared because it was mind-blowing, right? It was absolutely a disruptor to medicine, and I couldn't articulate any of it. One of the things that you had talked about at lunch that I was trying to bring back was the idea of the community. When you said to me, the way we change medicine and truly put prevention first is we change the mentality of I'm going to treat a patient versus I'm going to treat a community. Will you do that conversation again? That was mind-blowing.
Sure. So it started when we were discussing this. I mentioned that I was an antagonist to value-based care or pop health or whatever you want to call it, because I felt that it was individuals coming in and telling me what to do, and two, holding me responsible for a patient's actions.
Will you explain what that is? Just
So value-based care,
Yep.
all right. So value-based care, I'm going to try to crystallize it in the simplest way possible. It's creating a medical community that puts the patient first and institutes policies that improve not just the patient but their community and make them healthier. Healthy does translate. It does translate to spending less money. So yes, there's a money aspect. Nobody's doing anything for free, but we want to spend less money and then allocate that to a more appropriate resource. I'm going to give you an example. Behavioral health here in Arizona sucks. I mean, it's just horrible. Why can't we improve efficiencies in one area and then move that money to behavioral health to provide patients more consistent, better access, or improve their opportunities to get smarter medications to help them? It's not all about meds, but meds play into it, and meds are very pricey. So that's sort of the general concept of value-based care.
take one money out of one bucket, put it in a better bucket.
That is an end result.
Sure.
It's creating a process that you participate in, that you want to participate in, that improves your health, improves your well-being, improves your sense of self-worth, and saves money, right?
Yeah.
So it's like win, 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 win.
Sure.
So that's value-based care in a nutshell. And we're going to be held responsible for that. So for example, you want to get back to your doc. I'm not saying I shouldn't actually say it that way, but you're going to get a survey. Just really just ream them, because we will be tied in to.
Oh, I see what you're saying.
Yes, we're going to be tied into how we get paid by
The
these
experience,
surveys. Yes,
the
patient
outcomes.
experience, and the patient experience has two buckets. For the most part, right now going forward is. How was your experience as you went through the clinic visit? Check-in, MA, your medical assistant checking your vitals, rooming you. Did they make eye contact? Were they friendly? Did they discuss all your concerns? Did they spend enough time with you? Checkout, etc. All these things are allocated as specific questions to understand how well your primary care and or specialist visit went. And then they're going to ask you, are you confident about your doctor? Are you confident about the decisions they make? Well, from my standpoint, they're not doctors. So how would they know if this is a correct decision?
Are you asking the patient, do you trust what they're doing with you?
That's really what you're asking.
Okay.
Right? So it's really about that trust. So how do we create an experience where you have faith in us? And then that's why I said it's you wanting to comply. Because in the end, if you don't comply,
The game is lost.
well, am I a good doctor?
The outcomes would say no.
And that's
I don't comply to-
That's the difference between the old school medicine is nobody gave a fuck. Because if you don't do what I tell you, that's on you.
It's on you.
You
Enjoy
go-
that short life.
Go die.
Sure.
But now that comes back.
So there's stake in the
That
game.
comes back to me where they're showing me, hey, in your population of patients,
You didn't win them over. You didn't get their trust.
you're
in that.
influencing nobody. So are you really helping the community? That's the community angle.
That's
But
Are
doesn't the
you
actual
helping your
health
neighbor?
doesn't the actual health metric come into play, not just how I felt about the experience? I mean, you could be a total ass, but fix my broken leg, and it doesn't mean you're not a good doctor.
So yes and no. All right. So an aspect of care is the patient experience. The other aspect are those quality metrics. So
It's a report card with a blended.
But they both have to count.
They
do.
Nick is all about.
You could be
form.
the nicest guy in the world
They
and
do.
do me completely wrong, and I'm
But
still not going to be happy.
you guys
I
understand.
can't walk, but he was nice.
Yeah, exactly. But here's the thing. Are you going to sue somebody that you like?
I mean, no, but I'm also
That's
not going
my
to sue
point.
somebody who did the job correctly, right?
Oh,
Oh,
a
yeah.
lot of
Oh,
people do that.
Really?
Malpractice.
Yeah,
Oh
people-
yeah.
Too bad I'm not a
People's-
patient more often. It sounds like that'd be a good one.
Exactly. That's fine. You need a prostate exam?
3 years.
So it wouldn't be me. I got a friend who does that. So yeah.
It wouldn't be me, but I got a friend. But if
Yeah,
he's mean to
exactly.
you, let me know
Yeah,
because
well,
it won't go well.
Yeah. Well, he was in prison for a while.
It's okay. That's where we got good.
That's
Yeah,
experience.
what's meds that he was selling?
It's
and all
fine.
that.
It's fine.
Yeah,
It's
yeah.
fine.
I figured it was okay.
Lots of experience.
So you have a very valid point, and I love how you said it. So it is a report card, and an aspect of the report card is going to be the patient experience. The other part is quality metrics, and there's a variety of quality metrics depending on the specialty that we have to meet. Of which I don't want people crying over me, though I wouldn't mind that. Primary care has the longest list in regards to quality metrics that we have to meet to show that we're influencing our patient
Because your touch
base.
points are so great.
Yeah.
They have so many more touch points.
Absolutely, so many more touch points. But initially, I thought this was bullshit. You know, I thought this was bullshit.
Why?
You know, why should I
'cause it's
be
not
held?
my
Yeah,
issue.
why should I
It's their
be
issue.
held responsible? But as I become more indoctrinated in the program, so I started with IMS, helped create Patient-Centered Medical Home, which is a value-based care program that focuses on patient experience and improving doing whatever we can to help the patient be successful. I saw how the community improved. So when I got the data back and did analytics on it, like wow. We up.
Shit works.
Yeah, the shit works. It's like all of a sudden, we got 30% increase of people getting mammograms or catching breast cancer early. We're saving lives.
Yeah.
And I'm like thinking, okay, I kind of get it now. I kind of get it. And there is this sense of, help thy neighbor.
Yeah.
What I'm doing now is I'm helping you guys. It isn't you. It's you guys. I'm helping everybody here move forward and trying to find ways to be healthier.
Well, that's actually kind of a nod to original medicine, right? I mean, it used to be
Right.
way
The
back
community
when
doc,
there's a
right.
doc who happens to live in the town, and that's the town doctor, right? I mean, I grew up in a really small town in southern Minnesota, and it was like literally the doctor, primary care doc, knew everybody in the town because everybody in the town went to him. He was the closest doctor within 30 miles, right?
And you got free pies and
All the
like
things.
other shit. for
Well,
free.
and
I
then
mean,
you knew so
like
much
a chicken
about their.
and an egg. I like eggs. I like chicken.
But that doctor, imagine how much he knew about lifestyle.
Handpicked.
Just based.
well,
Just carry on with your damn chickens. I quit.
exactly. Well, the downside is that doctor walked in smoking a cigarette saying you can't smoke, right?
It's
Yeah.
fine.
So-
It's fine.
No,
But
but
I
that's
mean, like delivered. I have two brothers. I have a brother and a sister. Delivered all three of us, right? Like, there's a family. You start to know the family, so also the genetic health challenges and all that kind of stuff because there's a familiarity on both sides of the fence.
absolutely, and to a huge so the concept of patient-centered medical home.
Yep.
A medical home is bringing what you just said back to primary care. So the primary care doctor is the guy, the quarterback, whatever you want to call it, and they're going to get to know you very well, spend more time with
Right.
you, and help you navigate through how you can strategize being healthier, just like the old school country doctor.
Well, and I think that also maybe lends itself to the report card because there's more of a relationship. And if you have, if you're going, because I don't know, this is probably changing now, but for years, it's like every time I would go to the doctor for a checkup or whatever, it's a different person. And so there's zero rapport. It's a new person every time.
Continuity,
It's very,
what?
it feels very sterile. It just feels, you know, and, you know, at some
You're
level,
only as good as your chart.
you kind of convince yourself like, yeah, it's supposed to be sterile. I'm going to
Right.
see a doctor, right? I don't have an issue. I'm just getting a checkup. But there's an experience.
You want to know
that
the guy who does
Yeah, you
the...
kind of want to know the guy. You want to be
prostate
comfortable enough
exam.
to
Prostate
exactly. You want to be able to share, maybe have dinner first, and like you know, and share. I just feel comfortable
wines,
sharing
and
something.
flowers, then the prostate.
Yes.
We're
Hold
good.
my
Well, because
hand.
otherwise, like you know, hey, you know what? I've had this pain here for a little while. I'm just not going to say anything,
Right.
right? Because I don't feel that comfortable. But really, it's like, hey, doc, want to take a look at this? You know, like, but I mean, sometimes you can
Right.
really learn something through that process.
I completely agree.
Huge.
And to an extent, a lot of this really relates to trying to move things in that direction. So you're going to have medical communities that are successful, that are more friendly, more patient-centric, providing more of that connection that I think we do need. And then you're going to have the ones that are just kind of like burn and churn, right?
Yeah.
Burn and churn, burn and churn. And the nice thing is up to you to decide who you want to be your primary care, not just physician, but group, and that's the thing that's happening. So flipping it from a business side, what we're going to see, we're already seeing is a huge consolidation. So it's almost, I like to say that there's blood in the water, right? And the sharks are jumping on the chum. And
Control patient lives and migration.
Exactly. And Phoenix, market-wise, is one of the top 5 investment markets for medical businesses. And that's not going to be, the case forever, but it is right now. So with that, so I'm going to use Village Medical as an example. So, close to 2 years ago, I was the first physician that they hired. And now, by the end of the year, they're going to be over 200 docs, 40 co-located Walgreens, and that's just the co-located
That's
Walgreens.
200 quarterbacks that they just obtained, right? You can look at what happens. when you got-
Obtained as though like we're talking full time, like that's their only obligation.
Correct. And what they did is they did most of it through practice acquisitions.
Right.
You have a lot of physicians that have been around a while. They're getting kind of tired. They don't want to go through this sort of transitional process. They're used to old school, processes in regards to how they run their office. And now they got to do a lot of data analytics, which they're not really geared to do. So they're getting more burned out and they sell out. So, I just want to be a
wanna go to work
doctor.
and go home.
Yeah, I just want to be a doctor. You take care of the business aspect, and they're selling out with a premium, and they're making bank on their practices now, and they're coming in $6 billion buyout, right? $6 billion for Walgreens to buy out Village. I mean, that's I'm
Why
not
would you do
spilling
that?
any secret. It's 60%, but they own the majority. So I like to say you now work for Walgreens. There's nothing wrong with Walgreens. I think it's a good pharmacy, but that it's a good example of how physicians are moving towards that, are willing to sell out, are frustrated, and things are consolidating. So you're consolidating under a big primary care banner.
Why walk through the why that's a bad thing from a patient perspective, the consolidation?
It's
Why should we care?
Why should you care from a business standpoint or a patient standpoint? So the patient standpoint, what's going to happen is that over time, there's going to be less choice. So you're going to have a consolidation with a bunch of big groups. I don't know how many. Let's say, at least there's going to be, maybe 8 to 10 premier groups that you have an opportunity to participate in.
The Kaiser
but that's
model.
it. Well, it's a bunch of Kaisers running around.
Big beasts.
And having an opportunity to work with a small mom and pop primary care group is going to be impossible. So they're going to be the minority. You'll still have, especially in East Side, concierge opportunities because that's still lucrative out here.
Right.
It isn't on the West Side. It's hard to run concierge in the West. But those are unique, and not everybody can create a concierge practice, and not everybody as a patient can sustain the stipend. So a lot of people think, oh, this is great, and then realize that they want to buy perfume rather than see their doc. So, they spend the money somewhere else. Then they drop out. So what you're going to lose is you're going to lose in choice because there won't be as many people to decide where you want to have your care given. So you have to be savvier. The other thing that's happening, so Village is a good example of a vertical, vertical, horizontal. I'm dyslexic. So it's horizontal integration. So it's just primary care, right? Spreading. I keep hitting the damn thing. Spreading around all over the place. It's the first time doing a podcast.
You're doing great.
Matt will edit that out.
Yeah, exactly.
He makes
It's his
everything great.
fault. All right, pull it forward a little bit. All right, sorry. Where you can get a vertical integration, that's where you have primary care and you're stacking specialty and other services. So Village predominantly is horizontal. They are stacking some specialty services on top. But as a patient's understanding, what do you need and who's going to service that? And it'll go all the way up to hospital. Like Banner, for example, wants to be, in my opinion, a Kaiser. So they want to do everything, including have their own insurance product. Okay, well, there's pros and cons. Pro is we got everything. Con is they tell you where you go.
It hurts my stomach because now your payer is your provider. And where is the incentive piece for me really hurts my stomach. That hurts my stomach.
I don't love
Just
the idea
the
of my
model.
doctor working for a pharmacy, but that's maybe a little bit of a different rabbit hole. What about the specialist though? Because the specialist is kind of a different piece, right? So the way that IMS is integrating with specialists is much different from I'll use Village as an example, primary care, right?
Right. So the main difference is Village's focus is predominantly primary care at this time. So I say at this time, I think that they're savvy enough that they're going to adapt going forward. The fact that they're integrating with pharmacy is a good example of that. IMS's core has always been to integrate specialty with primary care. So what that allows us to do is to pivot more aggressively to provide specialty-based programs and move so quicker and much more efficiently. And the focus then in expanding really relates to what service do we have to provide the patient and how does a specialist help fill that, right? So it's patient-centric rather than, oh, yeah, get an orthopedic, make shitloads of money. Get ortho, make shitloads of money. Well, are we doing anything meaningful, right? Are we decreasing fall risks? So are we in any way preventing patients from going to the hospital? As we get older, fall's a big problem. Joint replacement is important, but does a person need a new joint at 50 or 70?
Right. Maybe we introduce a little exercise at 50 to push off a joint replacement.
Get
right?
the weight off,
Right.
exercise. You've got gel injections. There's a lot of different things that you could do to improve this person's opportunity where they have less pain. They are not going to fall. And on top of that, you're preserving, right now a joint lasts about 20 years. There's tech that's improving that. But we're all living to be 90. My dad, he moved in with me. My mom passed away about a year and a half ago. It was kind of expected. She had a bone marrow type cancer. So, she was suffering. So there's some relief in her passing.
Sure.
But my dad moved in with me. And he cornered me about a month ago. I think I may have mentioned this to you. And he said something interesting. He's 83. My mom passed away at 83. He said, Randy, I didn't think I'd be alive at 83. I didn't think I'd be alive at 83. And I said, Dad, tough shit. Suck it up.
You didn't die.
I did. That's what I
like,
said.
you're right.
Yeah, I said, look,
You're
you're so goddamn healthy that you're going to be alive another 10 years. You're going to be alive to be 93. So
plan and
stop
prepare.
whining.
Yeah.
Start, engage. Find ways to engage. Do things that you like. You're still driving. Start exercising so you can drive another 10 more years and not kill people on the street.
I'm not
I don't
driving
want
your
to
ass
pull.
around.
I don't want to pull your keys and have you complain to me that I pulled your keys.
Yeah.
So it's your job to get re-engaged and rethink what you're going to do over the next 10 years because you're too damn healthy. There's no medical reason you're going to die. So, and that's where we're at. We're going to live to be 90 at the least, whether we want to or not. So we got to do so healthy. So yes, I applaud what you're saying because we do have to inject more prevention. You don't want to get sick and then fix it. You don't want to get sick in the first place. Because you're going to be 90 and aggravating your kids, telling them silly things like that.
So how are you guys pushing that? I don't know if that's even
Pushing
the right
prevention?
way. How are you pushing? Because the comment you made a little bit earlier was, this is what I think you should do. Now it's up to you to go do it. But at the same point, that personal responsibility, in my opinion, is kind of so. As the guy that gets to select the healthcare plan that goes to my employees, our healthcare plan is geared largely towards a more patient-controlled model with a high deductible plan, right? So that benefits you taking your healthcare kind of into your own hands. There's a danger there, but there's hopeful expectance that people are going to care about their care.
Don't need this. Use your HSA for an investment purpose. Like, that's the goal.
Right. It's interesting how many people do, actually.
That becomes an incentive.
Yeah.
Right? It's like, I'm either keeping this money, I'm investing it, or I've got to go spend it
And within
everywhere.
those plans, and not that plans dictate care, but honestly, a lot of times they do, right? So that 100% preventative is covered all the time.
Right.
So get your preventative stuff done. Go in for the
Right.
checkups, do those types of things. But how are you pushing self-care?
Compliance,
What's
or
the right? I don't know what the right
motivation,
question
the
is.
empowerment. How do you do that?
That's so if I had the right answer, or if I had an answer that really worked 100% of the time, I wouldn't be here. I'd be on tour, man. I'd be in the White House. I'd be hanging out with Oprah because, it's like, oh, it's all the solution to healthcare, and, everybody's healthy, and who's that guy, Tony Robbins or something?
Yeah, I was thinking of his name at the same time too. Yeah.
So I'd be hanging out with him. Yep. I don't. What I could tell you is that there are techniques that do work. One of the techniques is what I call the mother effect. And what does your mother do? Do you have a mother? I think you do, right? So what is
She has a
what
good
is your
mama.
what does your mother do, or did when you were growing up?
Everything.
Well, she told you over and over and over again.
All the
Comb
stuff.
your hair,
Yeah.
brush your teeth.
every day.
Yeah.
So
I tell these guys the same thing
That's what we
every
have
day.
to do. So interestingly,
Take care of
statistics,
yourself.
right? Statistics show the more time I interact with the patient and remind them that, yeah, you need to quit smoking. Yeah, you need to lose weight. Yeah, you need to take these meds because you're gonna
The right
die.
answer was nag.
Yeah,
Mom
it
nagged.
is. Yeah. Well, I like to
Reinforced.
Say, well, nagging is a little harsh. I like to say I'm your mom or your
okay.
dad.
Okay.
So
I'm a
depending how
positive
strict.
influence in your life.
Yes, I'm a positive. I like to think so.
Yeah.
Conscience.
Sorry.
Conscience.
Yeah, conscience.
I'm your conscience.
But statistics show that the more opportunities to interact with the patient, the more likely they're
The
comply.
comply.
Yeah, and there's just a really good. This is when I was in medical school. A really good smoking study that shows a linear improvement in the amount of times the patient was seen, and the amount of times the physician then said you had to quit smoking. So if the patient was seen like 7 times and only told to quit smoking once, the coefficient was 0. They didn't quit.
Right.
But if they were seen 7 times and were told to quit each and every time, the coefficient increased to close to 40%.
Oh my gosh.
Yeah. So your mother
It's almost an
works.
accountability partner.
It is an account.
right?
That's part of it, right? So I do have patients that come in, they got their hand over their eyes, and
I haven't done it
they're
yet.
like- yeah, they're well, right. You've never done that. So they're like, don't even ask Dr. Keller because I know what you're gonna tell me. So like, what am I gonna tell you?
Well, I'm gonna say it.
Yeah, I should. I needed to eat right. I had to lose weight. I had to take my meds, and I had to check my blood pressure and my blood. And are you doing that? Well, you already know that answer. So,
Where do you go from there?
well, you
It's
just keep
like,
you
what?
keep doing the same
Keep the
thing.
message
Tell them, look, you
consistent.
know what you need to do. What's getting in your way? Is there any way I can help
Mm-hmm.
this? And then see where you can help them remove those barriers to be successful.
Mm-hmm.
And in general, does it work? I do think it does work because
Mm-hmm.
we've seen the statistics. Statistics, illustrate that the process in itself does motivate populations. That's how you have to look at it. You got to look at how is my population responding? Because if you just really think about the one patient that pisses you off, you're going to quit and not realize that there are,
You got to zoom out a little bit further. And
yeah,
look at the whole impact.
80%, 80% of your population, they are getting their colonoscopies or their Cologuard checks for colon cancer.
And they're not seeing you as often because they're not as sick, so you're not getting that validation.
Yeah,
that
and
stuff's
I say
working.
the best thing. Well, this is what I tell patients. The best thing to happen is for me to tell you I don't need to see you.
Yeah.
So I don't get upset if I don't see you. I get upset if I don't see you when I'm supposed to see you.
Yeah.
But if you're doing great, see you back 6 months.
So
see
in
you
this
back in a year,
in
whatever.
this new model, does it change? Like I go very visual, right? Does it change the physical way somebody goes to a doctor, or the doctor's office is gonna this disruptor, I'll call it, or pivot? Is it gonna be different? Do you walk in? Does it feel the same? Does it look? I mean, I understand I'm going more often. I'm having different conversations, but like, is the physical building different? Is the layout different? Is the path that I follow different?
I think The answer is going to be yes and no.
Okay.
Because you're going to have avant-garde thinkers that want to change that experience. I'll tell you, and I don't know the name of the group, but when I'm on the internet, there's this commercial, and there's this guy who's promoting the next gen of primary care, and it's all tech, so high tech. So you literally walk in and
it's even less human interaction, less accountability.
Well, so there's a nuanced edge that I think is going to be attractive to people, and it's 100% primary care focused. So what you do is you go in and you literally punch in. So they waive all copays, so no copays, and you make your own appointment, and you can be seen the same day. And literally, you walk in the room, and it's very Apple stylish, if you know what I mean. And you go back, and they have this Star Trek-like scanner. So there's this booth, and you literally, if you guys like Star Trek? Okay.
I'm thinking of the airport thing.
Well, I was going to say, if you do, there's the Borg has these cubes, and you kind of, okay, I forgot it. Anyway, it's this little like cube thing. You step onto it, and it scans your temperature. You put your hand in there, it checks your pulse ox, and there's other aspects.
Little hand comes out, does a prostate exam.
Well, exactly. So that's only you have to apply for the upgraded program. So you sort of have to want
I pushed
that.
the breast exam button
It
again.
says bend over, turn around and bend over. And then you go to the room, and this room has this literally huge video screen, and it has all your biometrics flashing in front of you. And they'll do their labs real time. So they'll go in there and draw the blood work that's needed. And it's prevention. You're not going in there because my knee hurts. Okay. You're going in there to understand what your health is right now and how they could create a plan to prevent disease. And that's their whole angle.
Okay.
So, and they have this I hate this thing. They have this laser ultrasound thing. So it literally highlights your veins. So that way the MA can go in there and very, less likely to miss.
Yeah.
And they put this in a disc, and this disc gets processed in 10 minutes. They have all your lab results on whatever they can't probably do everything. There are other things they're hooked in with 23andMe, and they'll do just literally the sea of genetic testing on what you may be predisposed to. And if you haven't done that, it's worth doing. I've done 23andMe.
I did.
And it says I'm very healthy and I'm going to live to be 125.
I called you about my results. I'm like, is this thing right? I think it is.
And well, the cool thing is they update things. So my genetic history started in South America. Now they changed it all. It's all coming from North Africa or something weird. It's weird.
Oh,
no, I'm just kidding.
New place.
But they as they get more data, they'll update things and give you that update. It's kind of cool. It's a cool thing. So if you look at that from what they're trying to provide, there's a certain sense of pizzazz and coolness and state-of-artness. And you can see where maybe a younger generation of individuals may adapt to that. I don't have the time to call. I'm just going to show up. I'll be seen the same day, do it on my time. I get this cool scanner that scans me like Star Trek, walk in there, and real time I can get some understanding.
But that's a wellness check. That's not primary care in my mind.
Well, wellness is primary care. It's an
I just mean
aspect
like your
of primary
annual
care.
physical is what I meant to say. Like it's like a once a year snapshot.
Correct. But what they're trying to do is promote that as being really paramount in importance. And if you think about it, isn't it?
Sure, the data's great.
Right.
But what you do with it's better.
But that's what they do is they help you customize a plan to improve it. And then you come back and see if they're, you're improving the plan. I don't know enough about them. If you have a problem, like I'm hemorrhaging from my colon, whether they can help you, right? Sure. So I can't.
All the visuals.
But yeah, they probably can't. But I do think there's an opportunity for them to be successful. And they're going to then change how healthcare is delivered because they have a population of people that are interested in that service. Yep. So it's going to be a mix.
Techie, cool
yeah,
stuff.
you're going to have old-time country doctors. So like my thing, I wear these Hawaiian shirts. You're going to get super ultra tech. Google, Amazon, Apple, that's where they're coming into healthcare. So I don't know if
isn't that crazy? Did you know that?
Yeah.
Well,
so they gave the finger to healthcare and the government and say we're going to reinvent and do it our way.
Well, think about the popularity of the Fitbit or the popularity of just the health app on your phone, all these apps to track, your food and your workouts and all that. It's kind of the same thing, a step, beyond, right? So that makes perfect sense.
Yeah, and they're going to take that.
Yeah.
They're going to take that real time data. Well, that's
He with the
I don't
most
like
data
anything
wins.
Bluetooth in my house because I think that the machines are watching me, so I have that issue. Nonetheless, a lot of people tie into that and it's getting that real time data, and that's where they're using that as the ground floor to create what they want to be a better system. So they want to reinvent healthcare to a degree. I think that's great. Let's see what they provide and then see how we can integrate it. I'm all for stealing their ideas. So if they can do something better, I'm going to implement it.
Sure.
I mean, that's my job as an informatics director. Even though I can't program my phone, I have to have my daughter do that. So you know what she did to me? She hacked my phone, and then you know how when you're typing a word in, it kind of like autocorrects.
Yep.
She did that with like tons of words. So I'm setting things like, "How's your fart going?" and things like that. I'm like, "What's going on?" It's like it's not even close to the word, and it took me a while, like. I don't know, 30
awesome.
seconds to figure out who did it. It's like, Randa?
I have an idea.
Yeah. So then I text her, and I text her, "Why are you farting on me?" And then she just starts laughing. She's like, "Ha, ha, ha." And then I have to beg her. It's like she's holding me
Will you
hostage.
undo this?
How much?
Yeah.
How much are you going to pay me to undo this? So total victim. I'm a total victim.
You birthed a hacker.
Yeah. Hell. So
Good job.
anyway, but I think you guys can see how to certain individuals that's appealing, right? And then certain individuals that's going to be totally alien.
Yeah. It makes sense. I mean, I think the feeling like you have some control over it, I think is important. And I can see the back end integration of that making sense. If you're going to do the I'll call it the techie visit, right? Like I can see a person wanting to do that like on a monthly basis to try to track progress.
Well, it's like how you feel like when you go out for a walk and you forgot your watch. You're like, the walk's not even worth it. I didn't get my steps in this stupid
steps.
right.
Yeah.
It's a mind, yes, but I think it's a control thing, right? I could see the effect of the work I put in. It's not just I went for a walk. It's
maybe a competition, right? Like
Sure.
the Peloton effect, where you're gonna wanna tie in with some of your buddies, and you're gonna do a weight loss challenge, and so you're gonna walk into the place and get your scan done every 30, 60 days, and that's how you're gonna measure your goals against people.
But
People
even
like
just
competition.
talking about what the product is or how it will be delivered, it instantly goes to, look at our conversation, naturally goes to prevention. It didn't go to, okay, well, what happens with acute care? What happens with heart disease? It moves the conversation a very different way.
Correct. I mean, the whole idea is if you want to cut costs, you have to spend more money in preventing illnesses. So the U.S. uniquely in the world spends far more money in interventive care. We're sick, let's fix you, as opposed to preventative care. And one of the things that I mentioned to you, in China, I can't say that in all of China, but in some of the provinces that I was in the martial arts or community was involved with, in order to get a cancer treatment, you get this little paper. In the paper, there's these little boxes. And in the boxes, you have to get a stamp. The stamp really related to Qigong or meditative or preventative services that you have to go and get signed off on. So there's sort of a sign-off process. And then you're able to get treated or have your treatment continued. Okay, we can say, wow, that's you're holding the patient hostage, and why should you do that? And that's ridiculous. Okay, well, think about it from a different perspective. Sure. That patient, is invested in their health. So from a cost aspect, they're more likely to succeed in their treatment because they're putting time and effort into being healthier. So they're an ideal individual to treat. So you can look at it from another aspect, say, okay, that's actually a good thing. Now, could that be implemented here? Probably not. You'll have people marching in the street or on, Congress
You would
again.
call it some kind of a privilege, but that's what healthcare is. You can't get the cancer treatment without the coverage to get the treatment. How is it any different?
So the argument to that is we should just give everybody treatment. And so that's the argument that you're going to deal with, right? Is people are just going to be like, well, how come you're going to give you treatment but not you treatment?
But right now that treatment doesn't happen.
My brain is kind of broken on this because I would be like, okay, so now I'm going to do a organ donation. And are you going to have to go through that similar process to qualify for?
You have to qualify to receive an organ.
Is that true? I don't know. I've never
Actually, it is. So I was going to mention that.
I've never given or taken.
One of the most, and here's it doesn't make sense if you talk through it. organ donation is very precious, and that psychology is exactly at play in organ transplant. You don't want to give it to a guy who's going to go drink and then kill off that
Here's
liver.
a liver.
When
You just get another
you
one
could have
in
given
5
somebody
years?
else and saved their life.
Right.
So there's a very, very tight process that you have to participate in, showing that, quit smoking, quit drinking. There's all these other things that you have to do to get the transplant. And if not, you get either kicked out or kicked down the list.
Yeah.
So then by comparison, are we not basically implementing that same strategy with cancer treatment and or expensive type
The
treatments?
China model would, right? That's kind of taken that into account.
The China model would take the organ transplant model, which we have, and move that to
Force compliance.
Yeah, well, right, exactly. Again, so first I want to say I am presenting different talking points.
Sure.
I'm not endorsing. I don't want people to go home. It's like people marching in front of my house. Like, oh, by the way, can you pick up the garbage? So we are, to an extent, going that way to a degree. It's a carrot and a stick. So initially, I'm sure you guys are familiar with incentive programs. Hey, if you participate in this, you get your BMI down, you check your cholesterol, you check your sugar, blah, 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 blah. You go to do your wellness physical. We're going to give you another $200 or $500 or whatever, right? All right. Well, let's take this the next step further, which is already occurring. Well, you do that, and now you're risk stratified. And we're going to put you into 3 categories, category A, B, and C. And if you're in category A, you get a significant premium discount. So, it's not just you get $500. We're going to charge you 20% less. If you're category B, your rates stay the same. And if you're category C, your rates go up. All right, now is that fair? Well, you can argue it both ways again. Why should me, a healthy person, pay for a person that's not healthy? Because that's what's happening. So when an insurance company looks at risk allocation, they don't want to go broke. So they're going to take a look at how many unhealthy, how many healthy, and the healthy pay for the unhealthy. The unhealthy, you're not paying for your own cancer treatment. You can't afford it. I am. But in doing so, the insurance company has enough lives where they can pay for your cancer treatment. And they can give you the perception, and it is a perception, that they can give it to everybody. But they can't, because if everybody came in and said they need cancer, they will go broke and they go bankrupt and everybody's out. And that's happened. There have been situations where insurance companies have gone broke and everybody, tough shit, go find another person who's going to pay for your care. So we already have sort of that model where we move money from one individual to another individual. So I don't know whether that's fair or not, but I do think a certain sense of what I call stewardship. People need to be stewards of their own health care. And if you do a good job, you should be rewarded. So at least you should be rewarded.
Well, your health will reward you. There, you got that going for you.
Yeah, but it's amazing how many people don't care.
Well, it's nuts,
right?
to me.
So look at the obesity rates. The obesity rates, diabetes, obesity, heart disease, they mirror each other. And that problem really is exploding, where 2 out of 3 people are considered at least overweight, if not obese. That wasn't the case in the 80s when I was in high school. I mean, that was like maybe 20 or 30%.
My kids saw a picture of Woodstock recently, and one of the boys said, and there, thousands of people in these pictures, and they're like, every single person in the picture is skinny.
Drugs.
Drugs. Maybe that's it.
I mean,
but they were doing more of the dance around drugs.
Most of them were
not the
probably
skinny
doing
drugs.
pot. And pot,
Right.
you get the munchies.
Counterintuitive.
Yeah, you get the munchies.
but they were too broke to buy the groceries.
Yeah, or that's it. That was it.
Yeah,
They're too tired, just nap.
Too tired.
So they haven't eaten in 3 days.
No.
So
It's true, but and correct me if I'm wrong on this, but they also then change the metrics to match our failure, don't they?
They slide to the normal.
I mean,
right?
what was healthy in the 70s is almost unattainable today, right? And so it's like they keep sliding our metrics to match our failure.
So the answer is yes, to a degree. And I've had these conversations with some of my patients, and especially with blood pressure. They move the needle down where, really the target's 130/80. It's bounced around. I can go into all the background related to that, but then you'd all be asleep bored. He just flashed you something. It wasn't.
What was it? I missed
it. It wasn't the finger. So it's it's just that when I have a patient come in, literally I get a frantic phone call. My blood pressure is 110/70. That's optimal. That's normal. But that's because everybody's used to 150, 140, 170, and that's the norm, right? They talk to their cousin, their neighbors. So it's like when I grew up in regards to being heavy, we only had 2 heavy people in the school, right? So there's 2 per classroom. Now it's 2 skinny kids and they have cancer. That's the norm. It's like what you mentioned. It's like, why is everybody skinny? Because we're now used to seeing pathology as being normal, and it's not. Look, that's just science. Don't get mad at me. Don't get upset at me.
There's a lot of shaming with that comment,
But it's science. And science shows that as you gain in weight, or what we call BMI, your risk goes up. The interesting thing is what happens is you prematurely age your system. You prematurely age your system. So you get a wear and tear type arthritis by the age of 30, when it should be by the age of 60 or 50.
You're just having to work harder to do the same things. Just mileage.
And you're adding more mileage because it's like putting on a 100-pound vest and expecting your joints to be happy about it. But it's an internal stress too. You're increasing internal inflammation. So think about it as this: you're creating a raging fire that's consuming it. So if you have, I'm from the Midwest, so it gets cold there. So when we're creating a fire pit, if the fire pit's raging, it burns out too quick, and then you're cold, right? So you want to nurture that
flame last.
You need to make that flame last. And what's happening with weight? All right, this is just science. As we increase our weight, we increase internal inflammation. We have other things that get derailed, which then compound that, and you're literally chewing yourself up from the inside out.
Pun intended on chewing.
So, well, maybe.
Full circle.
It's that. I mean, again, that's just science. So what we need to do is educate individuals, have them understand that. Look, it isn't about you being fat. Right? It's about you taking charge of your life and making decisions to lower your weight, improve your health, lower your inflammation. Understand that this is a marathon. It's like my dad. Tough shit. You're going to be 90, right? Now, the question isn't 90. It's what shape you're going to be in at 90. What shape you're going to be in at 50. That's the question. It's a quality issue. We will force you to be alive whether you want to or not. We'll drag your ass out of the coffin and do something to give you a new organ, give you a new knee, whatever it takes, right? Give you a penis implant, whatever you want.
Dad's back.
But quality.
Because
the point is fair, right?
It's like the Reebok pump. You just boom.
But if you run out of gas at 70 and you got to hang on the last 20 years as a couch potato, that's no fun,
You don't
right?
get to choose when the light turns off.
Yeah. And that's what I told my dad. I mean, I wasn't being harsh. It's like, look, get off the couch and stop being a crybaby. Right. You got 10 more years. At least you can drive at 83. You actually can drive. And you can connect with people. You choose not to. So if you choose not to, that's your fault.
Right.
So that's the thing. We will be alive. All of us, unless somebody offs us or something tragic happens, it's 90 now.
It's crazy.
It is crazy.
It's nuts.
I get a lot of people telling me, I didn't expect to be alive this long. People thought they'd be dead early 70s. They're now 83, 84, 85. And I can't, they're healthy enough that they're going to be alive to be 90.
Yeah.
I mean, that's a huge shift.
Big time.
If you take a look at the demographics, that's a huge shift. And these guys a lot of them can actually interact. And if I'm going to be 90, I want to at least be able to do something.
Right.
At least use the pump, right? I want to be able to pump it. So.
Well, how do we wrap on that? Thank you for coming. It's been weird.
I don't think we talked much about the economic side, but anyway.
You covered a lot, I think, of the conversation that people don't understand. So that's super helpful.
I think that people are still figuring that part of it out, and especially from our perspective on the construction development side, trying to cater to what people want when they haven't fully figured it out yet. And so I still think there's a discovery period that people are going through before they start to impact within our industry, development and construction.
What options are out there? What are we doing about it?
What do these spaces look like?
Right. How do we answer the calling?
Yeah. How do you make it more efficient?
Yeah. And that's, I think the key is that there's, integration is going to require a lot more clever architecture in the sense that, I need a more clever space. I need more efficient space. I need to integrate cardiology with primary care. I need a bigger space. So you're going to see a lot of shuffling as it relates to that. So from that aspect, this is a prime time to take advantage of that. And I tell you, we need help. I mean, physicians suck at business and real estate. So, having that influence, I think, is going to be helpful.
Like a collaborative answer
Yeah, it's
to
all
what they're trying to
collaborative.
accomplish.
We want to solve this problem. We got to work together.
It's very, very cool.
So,
Very cool.
Awesome. Thank you so much.
Yeah,
sure. This is fun.
it is fun.
Kept whacking this thing a lot. I
That's okay.
apologize.
It happens.
Yeah.
What do we do now? Isn't that what you always say?
what do we
at the
do
end?
now?
What do we do now?
You go home.
We can have the beer now.
That was
Yeah, I
interesting.
can have beer now.